Welcome everyone to the Insurance and Real Estate Committee's public hearing for March 2nd, 2023. My name is Carrie Wood. I'm co-chair of the Insurance and Real Estate Committee, and we'll open it up to any opening remarks. Co-chair Cabrera or ranking members, are you on and would like to share anything? Great. With that, we'll move to our speakers. First up, we have Senator Kevin Kelly.
Well, good afternoon. It's great to be back in the Insurance Committee. I certainly miss it. And thank you for the opportunity to address the committee. Representative Wood, Senator Cabrera, Senator Wong, Representative Pavelak-D'Amato, and all the distinguished members of the committee. It's great to be here. I really like the good work that's done in this committee. And like I said, I certainly do miss it. So I'm here to talk on behalf of and in support of Senate Bill 1116, an act concerning a state-operated reinsurance program and healthcare cost growth. For middle-class families, the cost of healthcare is anything but affordable. People are taking it on the chin every day, and family budgets are breaking. Last month, Senate Republicans unveiled a better way to affordable healthcare, a comprehensive set of legislative proposals aimed at lowering the cost of healthcare in Connecticut. Our plan does this through transparency, competition, and enabling the marketplace to work better for the consumer. The promises of the Affordable Care Act to create an affordable, accessible, and quality system have been anything but that for far too many Connecticut residents. Senate Republicans have pushed for action year after year, and we are again offering thoughtful and impactful solutions to provide that relief. We won't stop fighting until more affordable healthcare is in Connecticut. A key part of that plan centers on healthcare reinsurance. Healthcare reinsurance means putting our record state surplus to work by guaranteeing assistance in paying healthcare claims that exceed a certain amount. When the Affordable Care Act was passed, a temporary federal reinsurance program was created to help keep insurance premiums down. When the federal program ended, premiums in Connecticut skyrocketed. Now Connecticut has the ability to act on its own through what is known as a state innovation waiver to create its own reinsurance program. Our plan implements a state-based reinsurance program to reduce premiums. An analysis commissioned by Access Health, the state's healthcare insurance exchange, estimated that a reinsurance program would reduce premiums anywhere from 6 to 29.5%, depending on the investment made by the state. The program would be funded through the state budget, not through a new assessment or tax. While taxing insurers may be popular, those costs simply get passed on to the consumer and end up increasing the cost of your insurance. An annual investment of roughly $80 million, less than 0.5% of the state budget, will leverage tens of millions in federal matching funds and lead to an average premium reduction of more than 25% across plans. While I was disappointed to not see reinsurance in the governor's budget proposal, I feel it is our job as policymakers to help make that budget proposal better. Getting the waiver to pay most expensive health insurance claims will lower health insurance premiums by 30%. Imagine being able to essentially lower everybody's health insurance premiums by $600 per month for the average family of four. That's real money for real people with real budgets. The state has used a patchwork of federal COVID-19 relief funds to provide short-term premium relief during the pandemic. We must sustain this relief, and reinsurance is the answer. It is my understanding that even with a state-operated reinsurance program in place, some individuals in very specific circumstances may actually face a small net increase in premiums as the reduction in federal subsidy potentially outpaces the premium reduction. Senate Republicans stand ready to work alongside this committee to ensure premium relief is real and meaningful for all Connecticut families, including those that I just mentioned. Connecticut's average insurance premium for family coverage today is $24,000 a year. That's the third highest in the nation. Affordability is a crisis in our state. crushing insurance rates increases and raises health insurance costs. So therefore, healthcare is not affordable in Connecticut, but it doesn't have to be that way. There is a better way. That better way must lead us toward reducing health insurance premiums over the long term by implementing the state-based reinsurance program. I certainly hope you see the wisdom in this bill. I am available for questions.
Great. Thank you, Senator Kelly, for
Sure.
your work in this space. We are very much aligned with wanting to reduce the cost of care and provide better quality plans to those on the Affordable Care Act and the fully insured market that we regulate. I wanted to ask about the price tag of the proposal that you had mentioned. Is that $80 million an annual cost, or is it a one-time cost to the state?
Yes, that is an $80 million price tag. Certainly, there is a pass-through from the federal government, so that would also help mitigate that amount. And that would be for the full 30% reduction. Obviously, if the state were to make a less sizable investment, you could get maybe a 15 or 20 or 10%, depending upon where the level of commitment in the state is. But the 80% represents the 30% reduction. Mm-hmm. Also, keep in mind that part of our plan was initially included the benchmark. That was something that was adopted in last year's budget that the governor has advanced in years past. He started it with an executive order before COVID in 2020. And if we could reduce the cost growth in the state of Connecticut from the 10 to 12% where it sits now to about 4 or 3.5% like Massachusetts, if you extend that over both the Medicaid and state retiree plans that are significant, you could probably save that money in the state budget just by reducing the annual rate of increase in healthcare costs. So there are ways to do that. Certainly, I know there's a component in this bill to start to contemplate looking at hospitals. But I think if we exercise that fiscal discipline and put it back into reinsurance, we can solve this issue for all of Connecticut families.
So $80 million would get the maximum amount of reduction, but you're saying that we could invest, say, 40 million or 60 million and get just a different, reduction, basically, be depending on what the budget allows. But we can also offset that via, savings and other plans, is what I'm hearing you saying, plus apply some federal subsidies. So at the end, the net to the state could, in fact, be lower.
Yes, exactly. It would depend upon the investment. Yes.
Is there any way, we have 106,000 people on the exchange. We have about 250,000 people in fully insured plans and non-exchange plans that we regulate. Have you looked at using reinsurance for those plans as well, or would that be exempted because that innovation waiver only applies to the Affordable Care Act plans?
No, I think you'd want to use it across the spectrum, not just limited to the Affordable Care Act. This would be available to all plans. What your goal here is to lower premium for all families. And what you're looking at is the private market. Now, whatever tax subsidies are available and federal subsidies, that's where you get the pass through to the state of Connecticut. But I think lowering that cost once again in the Medicaid pool and the state retiree pool through benchmarking is where you can pick up some savings.
Right. And then you did explain the federal funding and how that interplays with this. So we wouldn't be risking people getting a lower subsidy with reinsurance, correct?
Well, I think the focus is on what's the premium they're going to be paying, because they may experience a lower subsidy because they're going to have a lower premium. But what you want to do is make sure that they don't have to pay more in premium at the end of the day. At the
end of the day,
so that you're going to hold anybody that's receiving a federal subsidy harmless. That's really what we're doing here. And really the folks that we're talking about that I did indicate may be adversely affected are people on the bronze plan.
Mhm.
And those may experience that reduction where I think if you take a look at that population, and it's something that I'd like to have OFA look at, see what the cost of that would be to maybe create a state-based subsidy to fund that offset so that we can do the whole program without leaving anyone behind.
Yeah, because the bronze plans are the ones with the really high deductible plans, right? Those
Right.
have the lowest premium per month, but their deductibles are extremely high. I mean, I'd love to be able to help with those high deductible plans because I feel like those people are basically uninsured. They're not going to the doctor with a $13,000, deductible.
Yeah, and this is part of what we've been striving to do is when you look at the average premium for the family of four is $24,000. If you could reduce that by $7,000, now maybe somebody who participated in the bronze might look and say, well, now silver's affordable. Now I can get into a better point of service type of plan and get real insurance for my family than having the high deductible where they're looking at diverting from primary care and actually going to it and making sure that we have a healthier community on the whole. But it all starts with trying to make those policies affordable. And that's what we're endeavoring here.
Great. Thank you for answering those questions. Any other questions from the committee? Representative Denning?
Thank you. Thank you, Senator. Nice to meet you.
Likewise.
So as I understand these plans, the states that are setting them up have to get a 1332 waiver through the Affordable Care Act and the federal government. Is that correct? Can you explain how that would work in getting the money back to Connecticut?
Sure. I mean, this is, once again, we're still operating on the Affordable Care Act platform. And part of that Affordable Care Act, they wanted to utilize the creativity of the states and set up a state innovation program, which is the W13, or not the W, but the 1332 waiver. So you're going to ask for the state's permission, or the state would ask the federal government for permission to do this. So that process takes a little bit of time. It's going to take about 18 months from beginning to end to occur. But what it does is we would seek federal approval to make sure that we don't run afoul of the Affordable Care Act. So you're going to do this within that context to make sure that all the promises and all the, I'm going to say the pre-existing condition, the essential health benefits are embedded in whatever products are sold in Connecticut, and that the reinsurance would actually work. Okay. And what we would do is the state would be contributing funds for the high costs of certain claims, and then also get federal reimbursement by the amount of both the federal tax credits as well as subsidies that the federal government would normally pay to consumers, but are saving because we're driving premium down, would now be redirected to the state of Connecticut.
And so can you break down for me what when you talk about this $90 billion, that's all Connecticut having to put forward, or is that what we get from the federal government and Connecticut?
That would be what Connecticut would initially pay as part of this. Yes, it's an $80 million price tag. And then you would be looking at what the reimbursement through the federal pass-through as to whether that would be reduced, if at all.
And would you change I know you can change the way that premiums are charged based on income and on age. Have you considered decreasing it for age so that people who are older and elderly were paying less?
Well, I mean, that's a function of actual insurance, is how they look at and evaluate risk.
Well, as I understand it, you do a 1332 waiver, you can ask for either one of these.
You could. I mean, we'd certainly be open to looking at ways we could make savings. The whole focus here has always been to bring premium relief and make healthcare affordable for middle-class families. Now, today we're talking about the insurance aspect. So whatever we can do to achieve that, if it's looking at income groups or age and gender, we would certainly do that, and we'd be willing to have that conversation to get this over the line so that we have the best 1332 waiver in the country. I think we're the insurance capital of the world, and therefore we need to be a leader in this space.
Thank you, Senator, and thank you, Madam Chair.
Thank you, Senator Wong.
Thank you, Madam Chairwoman. Thank you, Senator Kelly. And indeed, welcome back to the Insurance Committee. You cited the Wakely report and the research results and the savings of $24,000, which is the price of a Honda Civic, and literally with all things in a $7,000 savings to consumers. Tell me a little bit about the Wakely report. Who initiated it, and who is Wakely? Because it's important, as a data point that's being cited quite often. This is not just anybody initiating a survey. This is one that is based upon reputable reputation and also an organization that has a strong interest in healthcare cost containment in the state.
Certainly, and thank you for that question. This was initially and subsequently commissioned by Access Health CT, which is the Connecticut Insurance Exchange. And that goes back to, I think it was 2017, when we first started looking at this, and we made the proposal and the claims that this would actually reduce premium. Initially, they sent the report to Wakely, who opined that, yes, it would work. Then there was a follow-up question, because one of our insistence in this is that you do not want to, in trying to come up with the cost for payment, you don't want to put an assessment or tax on the policy or premium or the carriers, because what that does is it actually will embed additional cost into the premium. And that's what Wakely did in its second report, was looked at that and said, yes, that's in fact true. So if you want to get the full 30%, then you want to have a general fund appropriation rather than one that's going to put additional cost on the premium. And that's because what it does is you're trying to maximize federal reimbursement. And the way you do that is lowering the premium to its, as low as it goes. If you put a tax on that, it increases it. So you reduce the amount of help you're going to get from Washington. So to get the maximum federal benefit and the lowest premium, you want a general fund appropriation. And that's where Wakely went with the second report. But in both instances, it says that reinsurance works, it lowers premium, and this is something that I think Connecticut families would welcome.
And it's important to note that reinsurance is a familiar product in the insurance industry to kind of spread out risk, outlay some additional money, but it really is it's a vehicle that's used by many other insurance products to be able to offset cost. It's not anything new, but it seems to be an interesting phenomenon in healthcare, and I don't think a lot of people understand it. Is that true? I mean, reinsurance has been in existence for a long, long time in the insurance sector, and it does work.
Certainly, it does work, and obviously, reinsurance occupies a space in the insurance field in and of itself. What I think is interesting here is that reinsurance was a part of the initial Affordable Care Act. And that reinsurance corridor was paid for by the federal government. Unfortunately, the federal government, when it made its promise, didn't make the promise that that would be in perpetuity. It was only for about 3, maybe 4 years. And then once it dried up, the increase in premiums was exponential. It just took off. So this is really nothing new. It's really in the main of the Affordable Care Act. It's what the Affordable Care Act initially contemplated, but the federal government didn't maintain that promise. So what we're asking for is let's reinstate that promise at the state level We have the capability now with our state finances and budget. And we've started the benchmarking, which I think is an important component of this too, because we are going to get savings in the future as we drive down the cost growth on healthcare. And it's just time. It makes sense. It's reasonable.
Thank you. And talk to me about the timeline. I mean, you cited that the Wakely report at the first get-go shared these kind of financial saving data points nearly 5-6 years ago. And we lost an opportunity to set up such a plan to really take advantage of it. Now, for us to set up right now, tell me about the timeline. Let's not talk about lost opportunity, but right here and now, to set up such a plan, what would a state need to do to seek a waiver from the federal government, and what's the timing of that?
Well, I don't try to look back that much as to how long things have taken or how long we've been doing this, because then you start realizing how long you've been around here. But the thing is, you need to do the 1332 waiver. So first, let's get the bill out of committee. Let's get it before the General Assembly. Hopefully we can get it across that line. Then you would task, I believe it would be the Department of Social Services to seek that 1332 waiver. And that process, as I understand it, would take about 18 months. So if we started July 1 of 2023, we're looking at having that in place probably by January of 25, which is also an interesting date because many of the federal subsidies, and particularly those that were expanded under the COVID relief, those are set to expire in 2025. So if there was a time to do this, now is that time, because we could put ourselves in a position that if those subsidies go away, we would have a 1332 waiver in the works to then make Connecticut cable ready to provide that relief for families.
Would that then need to go to the Federal Department of Health and Human Services to complete
Sure.
the next step? Because there's many other players in this as well, right?
I'm not sure exactly where it goes on the federal level. It could go to Health and Human Services. It could also go to the Center for Medicare and Medicaid Services.
I appreciate that. And you're right. And I appreciate not looking back, but looking forward. This is an opportunity to begin an 18-month process to save consumers money, because that's the focus. And obviously, former director of the Office of Health Strategies, Vicki Veltri, in many conversations understood the importance of reinsurance. And my hope is that the administration, through current Dr. Deidre Gifford, as well as the governor's office, will be receptive to this new option, or it's an old option, to be able to supplement our cost reductions. I know the governor's made some budgetary and policy proposals related to cost containment in healthcare. I'm hopeful that they will be receptive to this as well. Your thoughts on that?
Well, my thoughts are that I know that the governor was very receptive to an initial piece of our plan, the benchmarking. We share a common goal in reducing healthcare costs for Connecticut families. I think this is a reasonable plan, and I'm certainly, I've always believed that good ideas find friends.
I appreciate that.
It's a good idea. And so to those who are committed to lowering costs, I think there's a conversation to be had.
Thank you. With the permission of the chair, I just want to follow up on the benchmarking aspects of this bill. I'm reading through many of the testimonies provided by my important hospital providers who've done a great job during COVID. But this, I believe, is an extension of the past benchmarking policy that we have implemented and are collecting data through the Office of Health Strategies. But we're looking to extend that into our hospitals, which is one of the biggest cost factors in regards to healthcare services. Can you elaborate a little bit more why this is a natural progression? in regards to utilizing and transparency and cost savings using benchmark in our hospitals, because you're having a lot of objections to it.
Certainly. And benchmarking began in Massachusetts under then Governor Charlie Baker, who did come out of the insurance industry. And it worked very well for the Commonwealth of Massachusetts. Now, what we know is that there are really two drivers when we look at the healthcare costs and what is making care so expensive. One is hospital costs, the other are prescription drugs. And I know that this bill looks at extending to hospitals. We've also got a bill that looks at more transparency in the space where prescription drugs occupy. But in both instances, when you know you have cost drivers in the cost of healthcare, I think it's only reasonable, and you do this in your family budget. If an electric bill goes up, if your tax bill goes up, you look at that and say, is there a way that we can mitigate this? Maybe not the tax bill, but certainly the electric bill, and you start to make changes in your household. Well, the same thing here. We know as policymakers that hospitals and prescription drugs are the major cost drivers. And the cost of healthcare is one of the drivers as to why premiums cost so much, because the premiums are paying for that care. So now looking at that and looking at the experience of what's happened in Massachusetts, bringing hospitals online, I think, is the next step. Is we started with the ready medical providers, but now to look at hospitals and to also have that transparency on the prescription drug space, I think is important. But we do need to be mindful, and I once again appreciate the concept in this bill, that you need to learn from experience. And one of the experience in Massachusetts was that the disability community wasn't really well represented. And in many instances, the quality and access to care suffered through benchmarking. So that's an aspect that we need to not copy from Massachusetts, make sure that Connecticut does it better. And so while we look at this space with regards to hospitals, it's also to be mindful that those that utilize and have significant costs in the disability community not get marginalized in the process.
Another focus in the bill and receive some critique is the site neutral payment. Now, you have been a tremendous advocate in regards to the senior population of aging in place and obviously care. Our hospitals are saying that these kind of site neutral payments will undermine their cost structure. What are your thoughts on that? I mean, the site neutral payment structure seems to be in line with aging in place and the effectiveness of that. Is that the rationale, one? But two, what are your what are your response to that in regards to site neutral payments that the hospitals are very much opposed to?
Well, once again, what we've got to look at is affordable. Let's back up. The promises of the Affordable Care Act were three. We were going to make healthcare affordable. We were going to improve access and quality. And so that's what you want to do in this area, is to make sure that we're doing all three all at once, and to make sure that people can afford the care that they need, and that it exists and it's maintains its quality and access. So I think that's what we're guided by, and that's what we would look for. And so once again, you've got to look at all cost drivers, and all aspects need to be on the table if we're going to solve the problem, because there's no one silver bullet in this space.
Well, I want to thank you for your thoughts and leadership on this issue. I'm grateful for your answers, and thank you, Madam Chair, for the indulgence of multiple questions.
Thank you, Senator. Representative Nuccio.
Thank you, Madam Chair. And thank you, Senator, for your testimony in that today. So I know quite a bit about the 1332 waiver process. And it's actually been done in 15 states, including Alaska, Minnesota, Oregon, Maine, Maryland, New Jersey, Wisconsin, Colorado, Delaware, Montana, North Dakota, Rhode Island, Pennsylvania, New Hampshire, and Georgia. And reinsurance plans are shown to work, right? They are definitely shown to help out with the high cost of healthcare, especially in the market that you're talking about. It's like a policy on top of a policy. A majority of these states, I would say, probably at least a good half of them, have funded their portion of the waiver through general fund allocations. And you're absolutely correct. By doing a general fund allocation, we do get a higher reimbursement back from the federal government for doing such. And I would be supportive, I am supportive of a reinsurance plan if we were to find a way to do it that way through the budget. I could not be supportive, as you mentioned, of one that would be an additional assessment on the insurance industry, because all that does is take the total cost of this program and put it on the smallest population, which is the fully insured population. So I'm glad to hear that you're more looking at this from the perspective of general fund and finding savings. Did I get all that correct? Just trying to listen in on all of it. I just want to make sure, sir, is that what you're asking for?
Yes, you got that correct.
Okay. So I would just like to kind of weigh some credence to the insurance committee here. That again, 1332 waivers are used quite frequently, and 15 states have already done this to create reinsurance programs that have shown to be successful in reducing the cost of insurance for certain populations. That being said, getting to the next thing that you talked about there, being able to leverage the all-payer claim database, and that you can lower the cost of insurance all you want. If you want to throw money at it, if you want to put more assessments on it, you can think of 800 different ways to try to lower the cost of insurance for people, but you're not ever going to lower the cost of insurance if we are not willing to tackle the cost of healthcare. And you and Senator Wong were talking about a few options that are out there. And, a lot of that is looking at specifically the cost of the hospitals, the cost of pharma, and then implementing solid legislation that's going to truly tackle that and stop just giving it mouth service. So, we hear a lot of political rhetoric up here, and I'm getting to the point where, we have a lot of political rhetoric about lowering the cost of healthcare. And I'd like to see us actually do something about that. So would you also then be supportive of moving forward legislation that is looking at how we can lower the cost of healthcare in the hospitals and on pharma, and in doing what Massachusetts has done, which is starting to find the industries, the hospitals and such, who are raising rates beyond the cost care benchmark?
Well, I know when I was on insurance, what Massachusetts was successful at was using benchmarking with carrots rather than sticks. And they were able to drive down their cost growth from 12% to less than 3.5% in about 6 years or so, 7 years. So I'd like to do it in that manner, where what you're going to do is get the stakeholders together, share information, and work at best practices by getting the industry's support and cooperation. It worked in Massachusetts, and they may have fines now, but let's see if that can't work first in Connecticut before we resort to fining conduct. I'm hopeful that we would find cooperation in Connecticut, and certainly wherever we can find savings, I think we need to do that. But let's start with that. That's what our benchmarking model is doing now. Let's extend that to hospitals, while also, once again, I think a big component here is also looking at pharma and making that whole process of the rebates, just all the structure, spread pricing, everything, and study that and look at that in a little more detail. I know that we got a lot of information from the transparency bill that we passed when I was chairman of this committee in 2018. But I think we need to do more with that information and drill down on it. But that was a step in the right direction. We need to continue that progress for the people of Connecticut.
Thank you for that. I would only just say that we have the all-payer claim database. We don't have full compliance of people who are entering their data. And I think it worked well in Massachusetts. Maybe it's just a different environment and such, but even they are at the point now where when it comes to the hospitals and rate increases, they're instituting the fines because it may have worked for a while, but now it's climbing up again. And unfortunately, we've had the all-payer claim database for a few years here now, and we haven't seen any kind of reduction at all. If anything, we've seen a pretty large increase in the cost of healthcare. So I respect the try first before we get there, but I think we have to have all these people at the table, and we have to have very, very stern conversations, not asking, not trying to find a way to get people to comply. I think we have to write tougher legislation that is making sure people are complying, and then we're holding those to those cost growth benchmarks, because it's just we're all we're doing is seeing the cost increase. We're seeing lower instances of care and higher cost for those instances. So thank you for bringing this bill forward. Again, if we can find a way to put this in through general fund appropriation, I would be out there screaming to the hilltops that it's something that we should do, because it is something that has been proven in multiple states to be an effective containment operation for healthcare cost. So interested in to see what everybody else thinks and where it goes. Thank you for your time, Senator Kelly, and thank you, Madam Chair.
And just as a follow-up to that, thank you for that question, because the all-payer claims data is one thing. When we passed that transparency bill in 2018, we were supposed to get even more disclosure that was disclosed to the state. I'm going to say it was this past March, about a year ago. We got it. In drilling down on things this year, looking at cost drivers, when we talked with the industries, they said they made full disclosure. When we talked with the state, they said they haven't made full disclosure. So there's a disparity in what's going on. And I think that's something that as policymakers, we need to dive a little further into to see what's going on, who's giving us the real skinny on what's happening, who's not, and is there more information there than we think. But I think this is an area that we've got some information. We need to see what's there. If there isn't enough, we need to get more. If there is enough, maybe we need to look at it differently to get better results. But needless to say, at the end of the day, we all need to be focused on issues like this so that we can get lower costs of healthcare and lower premiums for families, because they need the help. And that's why they sent us here to do the job.
I agree with you. And I think where we could maybe find a way to lure people in, I think our database would be much more useful if we could get administrative service ASO contracts to submit their claims data, right? Because they have no obligation to do that, but they are the largest populace. So seeing their spending trends would be very interesting to compare to the fully insured market. So I do think you're right. We have to make sure we're getting the best data, and we have to make sure we're getting it from everybody. And I just think we have to expand it beyond just what we're getting from the insurance companies, but we need to see, the hospitals and everything else. We really kind of need to dig in and make this a priority. So, again, thank you very much for bringing us forward.
Thank you. Representative Denning with a follow-up.
Senator, there's a Section 8. You talk about reimburse healthcare providers for covered outpatient benefit and amount that does not, based on the type of facility or provided, based on the lowest rate for all types of facilities. So I'm a little confused by this because I know that each facility provides or charges a facility fee. And I know Medicare is the foundation for which that facility fee is based on. And I'm just wondering, in other states that they have developed this, how have they done this particular negotiation with hospitals to decide, no matter where you go, hospital, outpatient center, surgery center, clinic, they get paid the same amount? And has it worked? And has it decreased costs?
I'd have to look at that. I'm not sure, but I'd certainly like to research that, and I can get you an answer and get back to you and continue the conversation on that.
Okay, because it concerns me, because that is very important to hospitals as to where they perform the procedures based on what they get reimbursed. And you're basically saying, I kind of like the idea. I'm just wondering the pragmatic costs for people providing care.
Well, whenever looking at any issue in this area, you always have to be mindful that there are still three promises of the Affordable Care Act. Affordability is one. Access and quality are also important. So when you go to a Medicaid or a Medicare reimbursement rate, that's often at a discount, which may help affordability, but it often impacts access and quality. So you have to balance to make sure that in the process, while you may make something affordable, you can't impact the access or the quality either.
I would love to learn more about how you would work this in the
Sure.
bill. Thank you. Thank you, Madam Chair.
Great. Senator Kelly, thank you for coming to our committee today and sharing this reinsurance bill with us. We appreciate it.
Thank you for the opportunity. It's been a pleasure coming back to the committee, and I look forward to continue working in this area.
We're always looking for members.
Thank you.
Next up is Joe Doherty.
Hi, good afternoon, Co-Chair Wood, Co-Chair Cabrera, and members of the committee. My name is Joe Doherty. I'm here to testify in support of Senate Bill 1037. So Senate Bill 1037 provides a program for self-storage owners to offer insurance to their customers. This practice is similarly used in industries such as travel, rental cars, and portable electronics, cell phones, laptops, things of that nature. This committee supported an identical version of this bill in 2019. I think importantly, at that time, only 31 states allowed self-storage owners to sell self-storage insurance to their tenants. I say only because now that number has increased to 42, including every state on the East Coast except for Connecticut. Just a little bit of background about why this insurance is important and why therefore this bill is important to our industry. Property stored in a self-storage unit is in the care, custody, and control of the tenant. And the tenant is responsible for insuring that property. The storage owner's insurance, in most cases, does not cover that property. For example, they don't have an insurable interest. They don't know necessarily what is being stored in that storage unit. So it's really up to the tenant to decide, okay, is this something that's important enough for me to insure, and how much insurance do I want, and those types of questions. Approximately 50% of storage tenants are in some form of transition. They are between houses, they've had a death in the family, perhaps they're returning from military service, and they don't have homeowners insurance or renters insurance that covers their stored property, or perhaps doesn't cover their stored property sufficiently. Standalone insurance coverage for stored property is not typically offered by insurance agents, and that's primarily because the insurance commissions are very low. When this insurance is offered at the self-storage facility, the premiums are typically potentially as low as $10 a month, up to maybe $20, $30, $40 a month, depending on how much coverage you get. Almost always the deductible is $0 or up to maybe $100. So it can also be beneficial to people who have insurance, homeowners insurance, if they maybe don't want to take a hit on their homeowner's policy. They'll have this specialty policy that, again, a typical insurance agent isn't going to offer, because there's just not that incentive for them to offer it with the very low commissions that are in place. Again, 42 states have solved this gap in coverage by permitting self-storage owners to offer this insurance to their tenants. These policies are underwritten by familiar companies such as AIG, Great American, and Hanover. All would be authorized to do business here in Connecticut. The Self-Storage Association supports the creation of a self-service storage insurance license in Connecticut for their owners to offer storage insurance to their tenants. I just want to briefly highlight a couple of important consumer protections that are in place in this bill, and I think address some of the concerns that the insurance department had raised in its written testimony on this bill. The first one is that storage owners cannot require their tenants to purchase this insurance. It's a completely optional insurance coverage. If they don't want it, they don't have to have it. It might be that the owner of the storage facility requires that they have some form of insurance, but if they have insurance through another means to satisfy that requirement, they, under no circumstances can they be required to purchase this insurance. Second, there is a fully licensed insurance producer. The bill uses the term supervising entity. That's either a fully licensed insurance producer or the insurance company involved in these transactions. So I think there might be a perception that you have this unlicensed individual at a storage facility selling this insurance, but there is that backstop of the licensed insurance agency and licensed insurance company involved in this product, involved in the training of the employees at the facilities who are actually offering this insurance, involved in the disclosures that are provided to the consumer when this product is sold. And ultimately, if something goes...
Mr. Doherty, you've reached your 2 minutes. Would you mind summarizing your testimony?
Yes, I will wrap up in about 30 seconds. I apologize. When this insurance is offered, that fully licensed insurance agent or company is involved. And ultimately, if it comes down to it, and we have not seen this happen in other states where this product's authorized, the insurance department has enforcement authority against both the self-storage owner, the employee of the facility, and the licensed insurance agent and insurance company, if it ultimately comes down to that. Thank you very much for your time today, and I'm happy to answer any questions the committee has. Thank you.
Hi, Joe. Thanks for coming here today. I just wanted to ask a couple questions. So the insurance department's testimony basically says that in order to do this, you must procure a limited license that's issued by the Department of Insurance, and their pushback is that it doesn't require any examination, insurance education, or other competency and fitness that licensed insurers participate in. What are your comments on that?
Co-Chair Wood, I did see that testimony that they submitted. That is not a requirement that we've seen in other states, in the other 42 that have this offering. Some of those states do require an insurance license. Some of them, like Rhode Island and a couple others, provide exemptions from licensing. I'll also note that it's not something that's required examination or continuing education for folks who offer rental car insurance, portable electronics insurance, and these other limited lines. It's a very limited product, very limited exposure both to the consumer. It's a nice add-on to be able to offer to them, and again, it's something that we have not seen. When we look at the complaints raised by consumers to insurance departments in other states where this is offered, this is not an area where the NAIC data shows that there are anything more than a very, very low incidence of consumer complaints in this area.
And can you share with us some of the consumer complaints in this space? This is typically categorized as inland marine insurance. And what the NAIC puts out is not the specific consumer complaint that's lodged, but the frequency of consumer complaints. And the frequency of consumer complaints for inland marine policies is very low on an annual basis.
And I'll also say, I apologize for not mentioning this in response to your previous question, Co-Chair Wood, but the insurance company that's involved, the supervising entity, they have to provide training to the employee to have them understand the product that's being offered and understand the guardrails that they're within. They are not fully licensed insurance agents. The bill makes that clear, and they're not allowed to represent that they have any authority beyond selling this limited product.
Great. Thank you for that clarification. Any other questions from the committee? Great, Joe. Thanks for joining us today.
Thank you.
Next up, we have Paul Kidwell.
Good afternoon, members of the committee. It's good to be with you, I think, for the second week in a row. It's nice to see all of you. Paul Kidwell with the Connecticut Hospital Association, and appreciate the opportunity to testify on SB 1116, particularly in opposition to the sections related to the benchmark that has been noted already, and to site-neutral payments in the bill. And let me first say, in the benchmarking process, hospitals in Connecticut have been at the table at the benchmarking process since its inception. Currently, 3 representatives, hospital representatives, sit on the OHS steering committee, which meets regularly on a monthly basis to assess annual spending growth, and work together to determine how we can slow the growth of spending in the state. So since the governor's executive order, hospitals have been at the table. We support the process, and we will remain at the table. We are excited that this will be the first year when publicly reported data is available. So the state legislature codified the benchmark last year. 2023 will be the first year in which we start to assess our performance against the benchmark. Hospital spending is included in our assessment of the benchmark. All of that spending is part of whether we reach the benchmark or we don't. Our objection to this legislation is the misapplication of how we measure the benchmark to hospitals. We measure the benchmark in statute on a per capita basis. Insurers, advanced networks, where you can assess a patient's full spending, is the way we measure the benchmark. Hospital spending is included in that. So I don't want anyone to have the impression that hospital spending is not included in the measure of the benchmark. It is. What we object to is the misapplication of the measurement to hospitals. Massachusetts was used as an example. Massachusetts does not measure its benchmark against individual hospitals. It measures them, as Connecticut does, against advanced networks. Those advanced networks are often the names of large hospitals and systems. But as an example, we are in line with Massachusetts. I think our argument here is we're just about to find out our first year of data. We started the benchmarking process in a pretty unique time in a COVID pandemic. So we're going to learn a lot about where we are relative to those benchmark values. We think we should all stay at the table, but right now is not the time to start making changes to how we're measuring the benchmark, particularly because the bill doesn't actually change the measurement, just change it how it's applied. On benchmarking, I would also say the All Payer Claims database has been used very effectively to identify spending trends. And I would encourage anyone to go to OHS's website and take a look at the presentations of the steering committee, where APCD data is used regularly to assess that spending included in hospital spending. Our other objection is related to site neutral payment, and specifically because the legislation ignores the fact that where you receive care, the facility in which you receive care does matter. It does matter if you're receiving emergency department care. It does matter if you're receiving care in a urgent care center, and it does matter if that care is being received in a physician office. There are services that overlap. There is a reason why reimbursement for an emergency department visit or a urgent care visit is different than a physician office. We're
Your
providing
3 minutes have eclipsed. Can you please summarize?
Absolutely. We're providing different services in those facilities, and those payments allow hospitals to keep emergency departments open 24/7, respond to pandemics, extend ourselves into cutting edge treatment and care. So we think there's a legitimate reason for those differing payments, and we respectfully ask that you oppose that section. I thank you for your time.
Well, thanks for being here today. So there's three components to the bill: the reinsurance piece, the benchmarking, and the site neutral payments. So basically, you're not here to comment on the reinsurance side. You're here to comment on the other two pieces.
That's correct.
Okay. How has the benchmarking been for the networks, collecting that data and working with OHS? Has that been a seamless process? Like, what's it been like the past year?
So I think OHS has been collaborative. They've included hospitals and systems, patient representatives, insurer representatives, physician representatives. This is our first year where we're doing data transfer. So all of the information, all the claims information that sit with the insurers is now, and with the advanced networks, is being shared. And so we're assessing, does the data look right? Does it, do we agree that the data is complete and accurate? I will say, one item that we're disappointed with is that we all know that inflation over the last 2 years has been pretty significant. We think the benchmark needs to better reflect inflation's actual impact on our economy and certainly on our expenses. So hospital expenses have grown $3.5 billion over the last couple of years. Nothing in the benchmark reflects what is happening with expenses. It only reflects what is happening with spending. So hospitals that have a 1% negative margin last year as a sector, $3.5 billion in more expenses, none of that will be reflected in the benchmark.
Why do you think that this change or upgrade to the benchmarking data collection is part of this bill? Is there something that
I think they, as we've seen in the APCD data, it shows that certainly hospital spending as the largest, the most expensive part of the system. It's an expensive part of the system. So we appreciate the transparency on our spending. In Connecticut, we annually provide information to OHS about our expenses, about our spending. We're now part of the benchmarking process, which will provide additional transparency. I'm certain that in OHS's report, they will note sector spending and spending by, I think this is I think this would be a misapplication of how we actually measure the benchmark, and frankly won't work because it's how the equation we're using to measure spending can't be applied directly to the hospital spending.
I mean, you're right. We're in an inflationary period. It's year one, the baseline. I mean, I think that it's almost like we have to look at several years.
Yeah, we would argue
in order to get a practical.
Yeah, we would argue we should give it at least a year to see where we're at. We agree. We all need to be at the table. We're at the table. Let's at least have a year where we see what's going on. I think we're going to need to assess that the first year, 2020, we had a pandemic. 2021, we had a massive rebound as people delayed care. And in 2022, we had pretty massive inflation. So I think our argument is let's stay at the table. Let's see what the data show this first year. Likely need to show what the data show the second year. And we can all adjust accordingly.
Great. Thank you for your comments. Any questions? Paul, thank you so much.
Thanks for your time. Appreciate it.
Next up, we have Stephen Sack.
Okay. Can you hear me?
Yes, we can, Stephen. We can't see you.
Okay. Hold on. Let me do that. All right. How's that?
Perfect. You're on.
All right. Great. Thank you. My name is Stephen Sack. I own a petroleum wholesale company here in Connecticut. And I want to just thank the committee for allowing me to speak. I'd like to address Bill 1115, an act establishing a surcharge on insurance companies in the state for underwriting fossil fuel companies. I oppose this bill because it will cost the residents of our state an unnecessary additional cost for insurance. The bill has many unintended consequences that I don't think were thought out when the bill was brought to this committee. First, some questions I have is how many insurance companies in Connecticut that are either based or registered in Connecticut actually underwrite fossil fuel companies? What will happen here is that this will push insurance companies to leave Connecticut, because if they insure a fossil fuel company, they're going to leave Connecticut, and then there's going to be less insurance companies competing for your business here, and it's going to drive up rates for everyone who purchases insurance in this state. Many companies like mine sell fossil fuels. We also sell renewable energy, and that it will negatively affect the transition to renewable fuels to reduce our carbon footprint. For example, Shell Oil is working to provide more renewable and low carbon energy options for customers through investments in wind, solar, electric vehicle charging, hydrogen, and more. ExxonMobil is funding a broad portfolio of biofuel research programs for enough energy sources. ExxonMobil is focused on advanced biofuels that do not compete with food or water supplies. Examples include algae, corn stover, switchgrass, methane emitted from landfills, and it's also investing in carbon capturing. Valero Energy has been investing in renewable fuels like ethanol with 12 plants. Valero is the second largest producer of corn ethanol in the world, a clean-burning, high-octane renewable fuel that lowers life cycle greenhouse emissions. Valero's Diamond Green Diesel joint venture is the world's second largest producer of sustainable renewable diesel, using recycled animal fats, used cooking oil, and distillers' corn oil to produce low-carbon fuel that reduces life cycle greenhouse gas emissions up to 80% compared to traditional diesel fuel. These are just a couple of examples of what traditional refineries are doing today. They're not just producing fossil fuels, but they're changing the fuels that we use to reduce the greenhouse gas emissions, and has a major reduction in carbon emissions going forward. This bill will have a negative effect on the investments in these products and ultimately cost to consumers with increased rates and less insurance companies competing in our state for their business. Thank you.
Thank you very much, Stephen, for joining us today. I was just wondering, what percentage of clean energy or green energy do you sell versus fossil fuels?
So today, we on our heating oil sector, there's a state mandate of 5% biodiesel, going up to 50% by 2035. We work very closely. We have the largest biodiesel refinery in the state right here in Connecticut on the East Coast. And so we do a lot of business with them in state here that produce the clean renewable fuels that we use to mix in with heating oil and diesel fuel to reduce emissions. I would say we're probably close to 20% of our sales right now are renewable fuels, and it's growing every year.
Yeah, I was just going to follow up with ask if it was growing. Are you constantly exploring how to incorporate more of that into your business?
Yes, we probably have just, we started with renewable diesel, well, not renewable, but biodiesel within the last 10 years. From 0 to about 20% right now, and we're just looking to increase more and more blends. There are manufacturers now that they just came out with a couple months ago a new burner for your house if you use oil in your house that you could run up to 100% biodiesel in your house, and essentially for about less than $1,500 you can reduce your emissions by 80%. It's the most cost-effective solution we have today of reducing greenhouse gas emissions, and it can be done today, not many years down the road.
Are you active in educating your customers about those technologies?
Absolutely. That's how we've grown in the renewable fuels is actively engaging and talking to our customers. I was a big supporter of the biodiesel mandate that we do have here in Connecticut now. So yeah, through education, through pushing more and more of the biodiesel is how we're getting it to go more and more and get bigger everywhere.
Great. Any other questions from the committee? Stephen, I don't think we've spoken before, had you at the committee hearing, so it's nice to meet you and thank you for sharing your perspective.
Thank you.
Next up, we have Eric George.
Good afternoon, Representative Wood, members of the Insurance Committee. My name is Eric George, and I'm president of the Insurance Association of Connecticut. We're here to offer comment in opposition to Senate Bill 1115. This would impose a tax on insurers that underwrite fossil fuel companies and an amount of 5% of the total premiums the insurer receives from fossil fuel companies annually, as calculated by the Department of Insurance. It's inappropriate to single out the insurance industry in the climate change debate, and this bill looks to have the insurance industry act as a cudgel against fossil fuel companies. The insurance industry does not play politics, and we should not be imposing new taxes on insurers. Why? Well, because insurance is critical to the state's healthy economy. Insurance acts as the oil and the grease to the state's economic engine. Insurance is the first to come to the aid of an economic tragic situation. Insurers also invest heavily in our capital markets. And Senate Bill 1115 fails to recognize that the insurance industry is a leader in the climate change arena. The insurance industry is leading in climate change by actively working to create real solutions to the threats posed by climate change. You can see my written testimony for examples of this. We also are disclosing much of the information, significant amounts of information related to our climate change efforts. We do this through participation in the National Association of Insurance Commissioners, the NAIC Climate Risk Disclosure Survey. This is a survey that acts as a risk management tool for state insurance regulators, our Department of Insurance, to request from us, the insurers, on an annual basis on a non-confidential disclosure of insurers' assessment and management of their climate risks. And recently, in 2022, NAIC went further and adopted significant revisions to this survey and included the TCFD, or the Task Force on Climate-Related Financial Disclosure, to be included within it and to align with the TCFD. TCFD is a framework that incorporates international business practices and climate risk reporting. The framework is structured around 4 thematic areas, which are governance, strategy, risk management, and metrics and targets. So you can see the rest of my testimony. Connecticut is a leader in this space. Our department is a leader in climate change. The legislature is a leader in climate change. You don't have to look far. You just have to look to 2021. When the legislature created a framework for reporting the state's progress towards addressing climate-related risks, monitoring greenhouse gas levels, bolstering resilience of insurers to the physical impacts of climate change. So we do ask you to oppose Senate Bill 1115, and I'd be happy to answer any questions.
Thank you, Eric. Great to hear from you. And, I think the intent of this bill is to look at some outside the box solutions on dealing with climate change that is happening drastically. I think while we're sitting here, it might be 50 or 60 degrees out. And that's been our entire winter, besides for 1 or 2 cold days. So, we appreciate your testimony and understand where you're coming from. But we're always looking to get creative in this space. I was hoping, I know you put this in your testimony, can you share some solutions that Connecticut companies are doing in to address climate change and other climate issues?
So I think if you look to the surveys that I refer to are significant. And I can provide you with probably the most recent information and disclosures in those surveys. But, companies do a varied amount of different things. They always are talking to their clients. They're always talking to their clients about things that can, reduce their exposure, climate change being one of them, and the effects of climate change being one of them. I mean, that's one area where insurers provide a huge resource, is helping individuals and companies and organizations understand their risks, including climate change related risks, and how to mitigate them. And the speaker before me, if I can just be given an opportunity, the speaker before me was talking about the number of insurers this would impact. The bill is drafted such that it would apply to all lines of insurance. So as I read that would be property and casualty insurers that write liability coverage to fossil fuel companies. life insurance companies that provide life insurance through a benefit package to their employees, health insurance companies that provide health care to the fossil fuel company's employees. So it would be significant. And we just really would like to dissuade this committee from moving further with this bill.
Thank you, Eric. Any questions from the committee? Thank you. Have a great day.
Thank you.
Next up, we have Samantha Dynowski. Okay. Next up, we have Carly Fabian.
Hello, everyone. Can everyone hear me okay?
Yeah, we can hear you.
Thank you. Hello, my name is Carly Fabian, and I'm here today on behalf of Public Citizen, a national public interest advocacy group with more than 500,000 members and supporters, including nearly 10,000 in Connecticut. I'm here to testify in support of SB 1115, an act establishing a surcharge on insurance companies in the state that underwrite fossil fuel companies. 2 years ago, the Connecticut legislature established itself as a leader on addressing climate risks in the insurance sector by requiring the insurance commissioner to incorporate state emissions reduction targets into insurance supervision and regulation. The legislature should now take the next logical step by protecting the public from the costs created by insurers that continue to engage in risky behavior. While the insurance industry often touts its role as an expert in understanding weather and climate-related risks, this understanding has not translated into sufficient action. Like the fossil fuel industry, the insurance industry understood climate change decades before the general public. But despite the advance warning and now additional guidance from the state in managing these risks, property and casualty insurers are dragging their feet on phasing out coverage for fossil fuel projects. Instead of managing these risks, these insurers are now quietly transferring the cost to ordinary people. Even as the costs from climate-related disasters grow, insurers have protected their profits by raising homeowners insurance premiums and deductibles, cutting out coverage for climate-related hazards, delaying, denying, and underpaying post-disaster claims, and in some of the most vulnerable communities, simply withdrawing. The industry has also left taxpayers on the hook for the multi-billion-dollar cost of adapting Connecticut's coastal regions to rising sea levels. By establishing a surcharge on fossil fuel premiums, this bill uses a concept that both the industry and every consumer is familiar with. You break it, you buy it. If insurers continue to cover risky projects that fuel climate-related disasters at the expense of policyholders and the public, it's only fair to ask these insurers to pay their share of the repair costs. Without intervention, low-income communities will bear the brunt of these costs. We strongly recommend that the insurance department use the 30% of funds directed towards it to support low-income policyholders in climate-vulnerable areas who are struggling to afford insurance premiums. And while the committee considers testimony from the industry, it should remember that these same associations were grievously concerned about the law on climate risk guidance before it passed. In fact, when this already enacted law was mistakenly presented as a new bill earlier this month, the industry did not hesitate to cry wolf about the risk and the burden. Additionally, most insurers are at least paying lip service to the need to reduce carbon emissions. For insurers with serious commitments, this will provide a competitive advantage. For insurers who have instead made empty promises, they should keep in mind that while the sky will not fall for them, sea levels are rising, and without a surcharge, Connecticut communities are the ones currently paying the price. Thank you, and I'm happy to take questions.
Carly, thank you for joining us today. I enjoyed listening to your testimony. Any questions from the committee? Great. Seeing none, we will go to Samantha Dynowski.
Good afternoon, Madam Chair, Chair Cabrera, and distinguished members of the Insurance Committee. My name is Sam Dynowski. I'm the State Director of Sierra Club's Connecticut chapter. And on behalf of the Sierra Club and our more than 40,000 members and supporters here in the state, thank you for the opportunity to testify today in support of Senate Bill 1115, an act establishing a surcharge on insurance companies in the state that underwrite fossil fuel companies. The Sierra Club is committed to defending everyone's right to a healthy world by tackling the serious challenges of a warming climate and unprecedented levels of pollution. A rapid and equitable transition to clean and renewable energy is our most powerful tool to address these issues. The International Energy Agency has said that in order for the world to limit warming to 1.5 degrees Celsius, there should be no additional investment in new fossil fuel supply. New fossil fuel development is fundamentally incompatible with meeting global climate goals and with meeting Connecticut's own climate goals. Surpassing the 1.5 degrees Celsius threshold is perilous, not only for Earth's climate, ecosystems, and communities, it also threatens the global economy, with current emission trajectories estimating 10% of total global economic value could be lost by 2050. Sierra Club supports Senate Bill 115 as a tool to address the fossil fuel underwriting and the ongoing damage that enabling fossil fuels does to communities. SB 115 will impose a fee on underwriting fossil fuel companies and use the revenue for the Microgrid and Resilience Grant and Loan Pilot Program to support distributed energy generation for critical facilities at our state's Department of Energy and Environmental Protection and the Insurance Fund at the Department of Insurance. The cost of mitigating, adapting to, and responding to climate change is significant and will continue to grow. And insurers need to do more to address their fossil fuel underwriting and the costs that climate-driven events are having on communities. Thank you for your attention to this matter and consideration of our testimony.
Thank you, Samantha. Has this policy been enacted in any other countries or states?
Not that I'm aware of. I will say that we are actively as a state suing ExxonMobil for the climate damage that they've done and the lies they told over the last few decades to keep us from the transition that we need to make. So we're certainly pursuing this issue here in the state in other ways as well.
I feel like we need to get creative when it comes to, tackling environmental issues and, rising sea levels and rising, temperatures. So this certainly seems like a really creative way, to tackle it. It's come up in years past. What do you think the challenges are to getting it over the finish line?
I think it's just will. This should be easy to do and provide essential funding. Communities, the cost to communities right now of dealing with climate change is already, they're already feeling the impacts. We see, massive flooding, street flooding in our cities when climate-driven rains are coming through in the summer. We have stormwater issues. We have, having to deal with sea level rise and putting up barriers along the coastline. These are all costs that our residents are bearing. And they're the result of emissions and climate-driven events. And so we need to do everything we can in our power to deal with that. And this is one way that can, I think, help fund the critical projects that we're going to have to do to protect people.
Yeah. And I mean, basically, you envision that the surcharge would go towards, I used to live in Bridgeport, and there are certain parts that would flood when there was a storm surge. You'd go to building like a breakwater or raising that section up. I've seen in other communities on the shoreline substantial breakwaters and things that are being built. So that's what you would, envision this money going towards?
I think we have there'll probably be a process. We'd have to put a process in place. There is one right now at the department with this pilot program fund, but be able to fund projects that need to be done in order to adapt to what's happening with climate change.
Great, thank you. Any questions from the committee? Great, thank you, Samantha.
Thank you.
Next up, we have Thomas Swan.
Hi, Representative Wood, Senator Cabrera, other members of the Insurance and Real Estate Committee. My name's Tom Swan. I'm the Executive Director of the Connecticut Citizen Action Group. I'm here today testifying in support of this bill 1115, an act establishing a surcharge on insurance companies in this state that underwrite fossil fuel companies on behalf of our thousands of members. Through their underwriting and investment policies, insurers play a much larger role in fomenting climate change than is recognized. The claims by the insurance industry that they are addressing climate change is like tobacco companies saying that they care about people's health, or I noticed in other testimony today, the Petroleum Institute saying that they're dealing with climate change. No insurance company in the United States has aligned their businesses with the pathway to global warming to 1.5 degrees Celsius, as is called for in the Paris Climate Agreement. A recent assessment of 30 of the largest property casualty insurers and reinsurers found that none of the US domiciled insurers ranked in the top 10 in terms of addressing climate change, while 4 of 7 ranked in the bottom third with scores of 0.5 out of 10 or less. In 2002, the California Insurance Department reported that insurers who operated in California had more than $535 billion invested in fossil fuel companies. And none of the insurers have pledged to stop underwriting new fossil fuel projects, as have a growing number of their peers in Europe. The actions their inactions and actions are fueling climate change that are resulting in higher premiums, policyholders having their coverage dropped, and forcing governments to expend more and more resources in resiliency and cleanup efforts. The proposal before you is designed to finance Connecticut's efforts to increase our resiliency and to help the insurance commissioner develop mechanisms to help policyholders get and afford coverage. For this program to work, we recommend the following changes. Clarify that the surcharges are only on property casualty insurance for fossil fuel projects. Provide more guidance on how the insurance policy would implement this policy, and also define fossil fuel projects more clearly. In closing, we believe this is a really smart and fair way to protect policyholders, shareholders, and taxpayers. We urge its passage and look forward to working with you to make this a reality.
Thank you, Tom. In your testimony, you made a comment that more and more municipalities are picking up the cost. I was wondering if there's a project in Connecticut that happened that you can point to where money raised through this surcharge would have gone to this versus having taxpayers cover it.
So there's been significant investments using, I believe, primarily state and federal funds for shoreline communities to shore up. There have been several along, I'm trying to think of the exact municipalities, but along some of our riverfronts. We're seeing challenges, whether it be, for example, in the, with flooding related to storms, I know in both the north end of Hartford and Bridgeport, where we've seen real challenges that communities have and an inability sometimes to even be able to get insurance policies. So the insurers, by not stepping up and addressing this, are really shooting themselves in the foot over the longer term, because they're going to be not able to write policies for more and more people are going to have bigger payouts. I know in the last quarterly report, both the Hartford and Travelers reported larger than anticipated losses due to a storm. Now, that's something that we should be really concerned about with their presence here in this state. How much are they lowballing the risk associated with their approach to fossil fuel over the long term in terms of exposure? And I think that's why we're seeing more and more proposals being pushed by shareholders to pressure them too. And I'm happy to say that we're getting positive feedback from a lot of actual employees who understand, or former employees who understand the risk that's going on and the importance for the industry to become a real leader on this front, where unfortunately, compared to Europe, it's embarrassing how poorly our industry here has performed.
Great. Thank you for your testimony. Any questions from the committee? Thank you, Tom.
Okay, thank you very much. Have a great day.
You too. Last up, we have Susan Halpin.
Good afternoon, Chairman Wood, Representative Berry, Representative Denning, and members of the committee that may be online. It's a pleasure to see you this afternoon. I'm here to testify in support of Senate Bill 1116, a state-operated reinsurance program and healthcare cost growth, the bill that you've heard previously today. We're really encouraged by the direction that's undertaken in this bill. As you've seen from data and published reports from the Office of Health Strategies and your own informational hearings conducted with the insurance department, it's the unit cost of healthcare that is driving the increasing cost of insurance premiums. By specifically including hospitals under the OHS benchmarking purview, it brings the most widely recognized cost driver in the system more directly into the agency's mission and goal. I heard the testimony earlier, and I think where this piece may have originated from is from something that I think came up organically through the community, and the perception that hospitals have said they're exempt from the benchmark. I think it may be some confusion that may be out there in terms of the attribution and how the benchmarking is calculated according to Paul Kidwell as he explained it. But I do think it's a problem out there that there's a perception, I think, among hospitals themselves that they don't feel that they're being held within the benchmark. So I'll just offer that. We really appreciate the recognition about the all-payer claims database. I think too often that database isn't recognized as the wealth of information that it can be. We work really well with OHS. They've been terrific, but I will say that there have been a lot of data requests that have been put out to the health plans, much in the respect that Paul Kidwell again detailed to you of how the data is collected. All the data in the benchmarking is collected from the health plans, and it can be resource intensive, and it can be expensive, and it can be challenging to make sure that the data is apples to apples and not apples to oranges. These are things we're working through. It is the first year, but it is challenging. And so we do appreciate the recognition in this bill that the all-payer claims database should be really utilized as the first go-to in terms of collecting data. On Section 8, site of service, again, I really appreciate the intent of this section and believe that it really goes in the right direction. If I might, we would respectfully suggest that a different approach, and perhaps one that gets more to the point, is one that requires billing from facilities to use the appropriate NPI number, National Provider Identification Number, or TIN number, tax ID number, for that facility where things are being where the services are being provided. So in other words, if you're a outpatient service in Bloomfield, but you're owned by a hospital system, you are billing under that outpatient facility and not under the hospital umbrella organization, which is a way to make sure that you're getting the benefit of those lower costs in those facilities that aren't physically on the campus of the hospital.
You 3 minutes have Eclipse. Can you please summarize?
Yep. Finally, I just want to lend our support for the continuing consideration of the reinsurance program. Senator Kelly did a far better job than I could in talking about the benefits of reinsurance, and we too think that's a worthwhile conversation. So with that, I want to thank you for your time.
Great, thank you, Susan. I wanted to just go back to a comment you made on the data collection under benchmarking and it being expensive. Is that cost passed on to premium holders?
I think all administrative costs, that carriers have to undertake are passed on in one way or another. Yeah.
So the state, we required that you collect all this data, and we are now doing another thing to raise premiums for people.
It is costly and resource intensive. I think we're going to get to a better place with the Office of Health Strategy as time goes on. They've certainly been willing to listen to our concerns and to have those conversations, and we're very grateful for that. But it's been a challenging year. I think if you asked any of the carriers, they would tell you that.
Okay, I think that anything that we are doing to increase costs to this very sensitive market, this committee would like to be aware of. So if we could keep the communication lines open on any sort of ongoing large cost to these plans, I would really appreciate to know more about that and how we can help streamline that.
Appreciate that.
Regarding the site of service, you heard the testimony from the hospitals. What is your reason for supporting this? And tell us in practicality how this is going on. If you can give us a few, examples so we can better understand.
Sure, I'd be happy to. And I did add in my testimony as well, in addition to my recommendation about looking at the TIN number or looking at the NPI number, you could also look at the Governor's Bill 6669 and where it bans facility fees, except in certain instances. I'll give you a personal example. He might not mind that I use him as an example, but my husband has hemochromatosis. It's a very common condition where you have too much iron in the blood. The treatment for that is to literally give blood and to, yes, you know it well, and to what's the word I'm looking for? I can't think of the word right now, but so he goes to a facility and they take his blood and measure, how much iron he has or doesn't have in his system. For a long time, he went to a facility that was not affiliated with a hospital. He was not charged a facility fee. Upon purchase of that facility, he was charged a facility fee. So that would be one way that you could certainly limit extra costs that are going to the consumer today. And also, I haven't looked at that bill enough to look at what identification number they're billing under, right? Are they billing under the umbrella hospital organization and therefore maybe getting a higher rate as a result of if you went into the hospital, the main hospital for that same service, would it be higher? Or are they billing under that appropriate tax identification number for that facility itself, in which case the rate might be lower. As we're looking at all of these issues around affordability, I think we want to make sure that the costs are being appropriately billed for the facility where the service is being rendered.
So in your example, there was a facility, maybe it was an independent, I'm not sure the ownership, but then it was bought by a larger system. And because it now has a brand name, I'll say on it, there was an additional facility fee charged.
Correct.
Does that happen with dialysis treatments and things like that as well? I'm assuming they could do that really anywhere.
Yes, true. And there was legislation passed a few years ago where that information, that potential for a facility fee has to be disclosed to the patient at the time that they're going, in for the service. But oftentimes, folks don't want to change where they're getting that service provided or don't want to change doctors, those kinds of things. So, there is disclosure language required currently, but it certainly does go to the cost of care. And for those that are operating on deductibles, and it certainly adds up quickly.
Great. Thank you. You have a question? Representative Denning.
Ms. Halpin, thank you for testifying. I have some, and thank you, Madam Chair. I always forget to do that. I'm getting better. So I'm very fascinated by both this Section 8 that you talked about, as well as the Governor's Bill 6669, which talks about the campus having a different fee if it's located, I think it's 2.5 miles from the main hospital site.
Correct.
So my question is, who decides the identification number of that facility, whether it's an outpatient center, freestanding surgery center, hospital?
I'd have to get back to you specifically, but if it's a tax identification number, I think it goes with the actual facility.
Is it done by Medicare? It's the Center of Medicaid and Medicare.
Christine? I think that's done.
Okay, so if a hospital has a facility farther away than 2.5 miles and off campus, and they're running it basically 8 to 10 hours a day. However, they're doing surgery there that requires, let's say, a robot that is very expensive. But to do the outpatient surgery and do it cost effectively, you need the robot. But they shut down at 4 o'clock, let everybody go home. Is that an outpatient center?
I think this could probably use more conversation.
Because that's my question.
Right.
Is that I get what the governor, I think I understand what the governor's bill is trying to do. And this one on Section 8 is confusing to me because it says that you have to reflect a reimbursement rate for all types of facilities, which means, and I'm not sure how that rate is determined, if it's a Medicare rate, whether it's a negotiated rate between a hospital and the insurance companies, or whether it's just inpatient, outpatient, and you mesh the two. But you can do an inguinal hernia repair as an outpatient in an outpatient center, and it should be cheaper than doing an inguinal hernia repair in a hospital because they bill differently for the facility fees. Correct. And I know,
and it's not just facility fees, it may be that negotiated rate as well.
Correct.
Yeah.
And then there's also medical specialists who go out and build their own facility so that they can capture that facility fee and catch the provider fee and any other fee that's involved with it. And then they build up their practice and they end up having this huge facility with inflated and now I'll say inflated value. And the only way that they can get rid of it is sell it to some other provider who can't afford it now because it's too expensive, or sell it to a hospital. And now it becomes a section of the hospital, or is it a section of the outpatient surgery center? So how do we decide, and especially if it's across the street? So the governor's bill is fairly nebulous. It says 2.5 miles, but what if the surgery center was built across the street? The hospital now owns it, but they run it as an outpatient center and they bill for it as a hospital. This is all very confusing to me, how this is done here.
And I think you raise very good points. I mean, one of the reasons why a hospital is charging a facility fee is because that main campus is open 24/7, right? It's staffed 24/7, regardless of whether there's folks coming in for services or not coming in for services. It has to have a high, oftentimes if you're going into the hospital for a particular service that can be performed outpatients, because you have higher risk factors, right? So they have to be prepared to handle that. So there's good reason perhaps to have those facility fees at that main campus. Those may not exist at your other example, whereby, the doors are open from, 7 a.m. They start very early, I know, until 4 p.m. or 5 p.m., et cetera, but they're not operating on a 24/7 basis. Is there a distinction in the tax code for that? There may be, I don't know, but I would imagine that TIN number reflects those, reflects that in the way that it is applied to those different facilities. So I think what we've seen over time is, as there's been consolidation, there have been consolidation of billing practices, and certainly, a lot of consolidation makes sense when there's purchases that are made. But if that facility that was, let's say, 4 miles or 5 miles away used to be billing under its own TIN number and is now billing under the main campus TIN number, you're now paying that higher rate and that facility fee potentially. So I think you're right. It warrants additional conversation, and I don't know the answers to what you're raising. I do know that it's been a concern across the nation that carriers have seen, whether it's been, I think it's evolving of the concern here in Connecticut. It's certainly something that across the country has been problematic.
Just your opinion, because I don't have the answer. Let's say you have a facility that's away from the 2.5 off campus. We're going to go by the governor's definition, but they have an urgent care that's open 24/7. Does that make them more of a aspect of the main campus because they have a 24/7 urgent care, even though it's billed at a lower rate, than if they did not have 24/7?
Asking for my opinion, so I'll give my opinion.
I'm just trying. This is. I mean, I have to tell you, I'm part of the problem here. I opened up surgery centers throughout my career, and I know how this game is played. I'm trying to figure out how we can make the rules more fair.
Right. I know there's a difference between an urgent care center and, for instance, a standalone emergency room that the governor's bill talks about. Marlboro, which was run by Marlboro Clinic, which my family uses down the road on Route 2, is owned by Middlesex. It is a fully functioning emergency room department. There is a difference between that, I think, and going to a 24-hour urgent care clinic. I think they have a greater capacity to handle, higher needs and perhaps, higher staffing levels and other requirements. So, what the identification number and how that ties to whether something is a surgery center, an urgent care center, a standalone emergency room, I can't say, but I think it certainly warrants further conversation.
I really agree with you on that. Let's keep talking. And thank you, Madam Chair.
Thank you. Any other questions?
Thank you.
Thank you, Susan. That concludes our public hearing, and we are adjourned. Thank you.